Hello all, welcome back. Today we'll be talking about the EMREE recall exam that I have attended. It's not going to be an extensive question and all the options. It's going to be an overview of what has come in the exam and what are the topics that you need to focus on. Especially I'll say you familiarize with the images, especially ECG, X-ray and the drama questions. So let's get started. All the best for all of you who are appearing this cycle. So acute otitis media, what is the causative organisms? Usually in children it's Streptococcus pneumonia, H. influenza and Moraxella catarrhalis, and there were a combination of these options. In the option it was Streptococcus pyogenes, so it is actually Streptococcus pneumonia, H. influenza, Moraxella. So H. influenza and Moraxella seemed the right answer. Again, acute otitis media, what is the management? It is amoxicillin. So they mentioned there is bulging of the tympanic membrane, so it is acute otitis media, and you give amoxicillin. Now, another patient who is a young boy with debris in external ear, there are no systemic symptoms, no fever, so it's not otitis externa. So for debris, you can wash with hydrogen peroxide. Otherwise, if it was otitis externa, especially with history of swimming, you have to expect Pseudomonas and give anti-Pseudomonal antibiotics. You have to know what are the anti-Pseudomonal antibiotics. Among penicillins, piperacillin, tazobactam, meropenem can act, cefepime. So those antibiotics can be against Pseudomonas. Now another question on concussion. So concussion is actually due to traumatic brain injury. There is no actual CT showed nothing. There is no internal bleeding. So it presents with headache, mild memory loss. There is problem with concentration, balance, mood, sleep. So this was the description of that. So you have to also identify what is SDH and EDH. They may give also CT. So it always know what is EDH, SDH and SH. So EDH usually due to trauma by the rupture of middle meningeal artery. Since it is an arterial bleed, it is more dangerous, and there is a classic description of lucid interval, and it is biconvex in shape. So it is outside of the dura. Lucid interval means the patient initially has a loss of consciousness, then they have awareness, so that is called lucid interval. After that they may deteriorate. So you have if you suspect EDH, always do a CT before sending the patient back home, because if you send without a CT and the patient collapse, it is the major negligence from your side. So it is EDH with lucid interval, middle meningeal artery, and it is biconvex in shape. SDH, again due to trauma, it's crescent shaped. It may cause midline shift and mass effect. So you may have to intervene surgically. It is due to the rupture of bridging veins, and it may present with persisting headache. Subarachnoid hemorrhage, again the classical description is severe headache, the worst headache of their life, usually in elderly due to berry aneurysm and the rupture of aneurysmal rupture. So that is SH. Under the patient on central venous thrombosis on heparin, there is worsening. How do you manage? So you have to go for endovascular repair, and there was no bleeding, so you repair endovascular. A patient is described as having thyroid with retrosternal extension, and the X-ray is given, and the options included superior mediastinal widening, mid mediastinal widening. So it is actually superior mediastinal widening. Here you can see this is the mediastinal widening with tracheal shift. Now a child with Turner, where there is webbed neck, widely spaced nipple, with edema of hands and feet. So Turner can have lymphedema, congenital lymphedema, and the option included problem with lymphatic flow, that is lymphedema. Now another description of parotid swelling, where the swelling is above the angle of mandible. It's not highly mobile because it is attached to the zygomatic bone, so it is parotid. Usually in elderly, if it is a tumor, it is usually a mixed tumor called a the pleomorphic adenoma. Now, another child who is brought with absence of red reflex in one eye. Her sibling also had removal of eyeball due to this the same problem. So it is retinoblastoma. What does it predispose to? So other than retinoblastoma, it predisposed to osteosarcoma. So you have to know the cancer syndromes and the associated cancers. So in retinoblastoma, the option didn't include retinoblastoma, which becomes then too obvious. So it is osteosarcoma. Now, most specific indicator of chromosomal anomaly, it included neural tube defects, polydactyly and all. Neural tube defect seemed like the answer. I'm not sure. If you know the answer, comment down below. And the other options also. Another patient who is diabetic, taking medicine, also taking sodium valproate for seizure prophylaxis, and child is born with neural tube defect. They are also given an image of neural tube defect. What is the culprit drug? It is sodium valproate. So you have to know the teratogenic drugs and the usual problem with the teratogenic drugs. Now, in child with iron deficiency started on iron tablets, how long will you give before checking the iron status? It is for 3 months, then 2 to 3 months, and then you have to check and then decide on further workup and further management. Now you have to also identify iron deficiency anemia. It is mainly low MCV, high RDW. So it is nutritional anemia with usually iron deficiency. The peripheral smear can show pencil cells, poikilocytosis. An elderly with iron deficiency always rule out cancer with endoscopy and colonoscopy. Now again, as I told, cancer syndrome is very, very important. Lynch syndrome was another scenario with ovarian and colon cancers in the family. A child with delayed passage of meconium presented on day 6 with abdominal distension. It was only on day 2 that the child has passed, the neonate has passed meconium. So it is likely to be Hirschsprung disease. Now, what is case control versus cohort? It was a question on cohort. So always remember, case control starts from the disease and you look for whether the exposure was present or not. So there can be a recall bias. Cohort start from the exposure and then we follow up for a particular period of time to see if the disease has developed. So cohort is usually prospective. It's not that it can't be retrospective. But usually when we say cohort, it's starting from the exposure then following up until the disease. Case control is starting from the disease to see whether they have had exposure in the past. Now another scenario when there is a ruptured Baker's cyst associated with rheumatoid arthritis. What is the specific marker? So in rheumatoid arthritis, it is anti-CCP, which is more specific than your rheumatoid. Then a patient after road traffic accident, there was subcapital femoral neck fracture. There was splenic laceration, but not so severe. They have decided to manage conservatively. There was rib fracture also, which was again decided to conservatively manage. What will you do? Will you wait until doing a re-CT to analyze the splenic laceration, or will you do a subcapital femoral neck fracture management? So the patient was stable. Nothing indicated that the splenic wound needed a revisit. Nothing indicated that there was a need for waiting for 24 hours. So it is the femoral neck fracture management. Another question from preventive healthcare aspect. A healthy lady in her postmenopausal age, she was brought by her son with an intent to do a general checkup. So her lipid profile was given. Cholesterol was a bit high. LFT was LDL was a bit high and HDL was a bit low. What is the advice that will you give? So the options included giving hormone replacement, but she had no postmenopausal symptom. To give statin, but she had not high cholesterol, no diabetes, no cardiac history. And the option also included diet and exercise. And another option was do nothing. From a preventive aspect, in an elderly lady who is who's having risk factors for diabetic, general risk factors, she may be advised on the importance of disease prevention. So she may be advised for good diet and exercise, to move around, because they may be having a sedentary lifestyle. And there was not explicit mention of sedentary lifestyle, but among the options that seemed like a logic thing. Now, patient with brown rash, hyperpigmented over the chest. It was scaly and microscopic examination showed hyphae. The option included both tinea versicolor and seborrheic dermatitis. Seborrheic dermatitis seemed like the answer. Tinea versicolor is usually hyperpigmented. It's not like it can't be hyperpigmented, but it seemed like seborrheic. Another child with itchy rash over the shoulder. There is previous history of eczema, and the image was something similar to this. And the living condition is also not so hygienic. So what is the diagnosis? It is eczema herpetic. Now a lady with this discoloration over the face. So there is difference in the pigmentation. So it is likely to be malignant melanoma, which is called lentigo maligna when it's over the face. Another scenario of rubeola, that is measles, where the rash has spread from behind the ear to throughout the body, and Koplik spot also, which is seen inside the buccal cavity. Remember, you can give vitamin A in measles. And another question where they asked what is the spread of measles, it's by airway. Another wherein they mentioned about BPPV. So they talked about the Dix-Hallpike manner, which is the diagnostic manner. So D for diagnosis, that is the diagnostic manner, and Epley is the treatment maneuver, otherwise called the canalith repositioning maneuver, because canalith means the stone inside the ear canal. It is repositioning. So that is a canalith repositioning maneuver. Now, Rini versus Weber, you have to know what happens in Rini and Weber in sensory neural hearing loss and conductive hearing loss. In sensory neural hearing loss, Rini is normal, it's a conduction more than bone conduction, but Weber lateralizes to normal ear, which means if the Weber lateralizes to left, there is right sensory neural hearing loss. In conductive hearing loss, Rini becomes bone more than air, and Weber lateralizes to affected here. So if there is bone conduction more than air conduction, suppose in right ear, with Weber lateralizing to right ear, it is right conductive hearing loss. So you have to know that. Now diverticulosis, what is the problem with diverticulosis? It is low fiber diet. Now patient with mitral stenosis murmur in pregnancy, coming with some kind of heart failure picture, what is your next step? So you can do an echo. That was the option. Now pericarditis, what is the ECG finding? It is concave, widespread ST elevation, and the specific finding is PR segment depression. It is concave, not convex like in your ST elevation MI, and it's also widespread in all the leads, limb leads and chest leads. So there are stages of pericarditis. First, what you see is your diffuse ST elevation and PR depression. The scenario may explain that there is chest pain, which is relieving with sitting forward. Aggravating when they're lying down, there is pericardial rub. There may be a history of viral infection as well. So the first thing is diffuse ST elevation, PR depression. Then the ST and PR returns to baseline. Then there is diffuse T-wave inversion. And finally, the normalization of ECG in stage 4 pericarditis. Now you have to know what is Torsades de pointes, usually with hypomagnesemia in a setting of alcoholic patient who is bound to have hypomagnesemia. So Torsades de pointes means circling around a point. That is what it translates literally. So this is what it seems like. So in the exam also, it was an alcoholic who was admitted for something, and the ECG showed something like this. The cardiac monitor showed something like this. So what is your first line management? It's magnesium sulfate. Another scenario wherein the patient had a history of COPD, now with right heart failure. There is peripheral edema, but the lungs are clear, so it is right heart failure. What is the kind of tremor you see in hyperthyroidism? It is fine tremor. The option also included coarse tremor, but it's fine tremor. Now, hyperthyroidism in a symptomatic individual, what do you do? Do you do ultrasound or you give levothyroxine and then monitor the patient? The lab values were given, so it is symptomatic hypothyroidism wherein you have to give levothyroxine. Now, another scenario wherein it is Cushing with ectopic ACTH. The high-dose dexamethasone suppression test was negative, which means pituitary is not the cause. There is some other ectopic site which is producing ACTH. Could be a lung malignancy, so it is workup for primary malignancy. Now, ketoacidosis, what is the next step? It is IV fluid. Definitive management of eclampsia is always delivery. Now, severe preeclampsia, what do? Do you give magnesium sulfate and then take up the patient for delivery, or do you do CS right away? So it depends on the scenario and the status of the patient and the status of the baby as well. Now, a patient with amenorrhea for 3 months with previous 2 cycles being heavy, what is your first line investigation? Is it beta HCG? The option also included TSH, but amenorrhea in a reproductive age group always rule out pregnancy. Also, abdominal pain in reproductive age group always rule out ectopic pregnancy. So it is beta HCG. Now, there were 2 questions on first trimester recurrent miscarriage. So, first trimester recurrent miscarriage could be due to chromosomal anomaly. So, you may do karyotype of both the parents. It could be due to prothrombotic phenomena like APLA. So, you can do beta cardiolipin, lupus anticoagulant. In second trimester recurrent abortions, it's usually due to the uterine structural anomaly, like the septate uterus, because as the fetus is growing, if there is structural anomaly, they cannot sustain and go in for abortion. So you have to know the terms of the abortion, like threatened abortion, missed miscarriage, incomplete abortion, inevitable abortion, complete abortion, all of those things. Now, another scenario when in intrauterine there is no gestation sac, there is a 3 centimeter adnexal thing, so it is ectopic and the patient is stable. So what do? The option included salpingectomy, but it was a young patient with no children, so you can't right away go in for a salpingectomy, especially when the patient is stable. So you can do medical management, especially up to 3 centimeter adnexal lesion. Now, molar pregnancy in an unstable ongoing bleed, you do surgical evacuation. So you have to know what is a complete mole, what is a partial mole. Okay, complete mole means a complete mole. It is completely molar. There are no fetal parts. Partial mole means there are some fetal parts and some mole-like thing. And complete mole has more predisposition to the choriocarcinoma. Now, another scenario of multiple myeloma. So remember, multiple myeloma has Crab symptoms, which means hypercalcemia, renal problems, anemia, bone light depletions, and the plasma count will be high. Now, what is the cause for left shift of oxyhemoglobin curve? So you have to know this: what is left shift, what is right shift, what are the causes of left and right shift. So remember, if there is it is a sigmoid-like curve, and if there is a left shift, for example, suppose this is the 50% mark of the hemoglobin concentration, the corresponding partial pressure of oxygen in the original and in the left shift, if you compare, in the original it is around like this, and left shift it becomes less. That means to achieve 50% saturation, you need less oxygen or less partial pressure of oxygen, which means affinity increases. So as you go to the left, affinity increases. Now suppose there is a right shift. What happens? For achieving the same 50% HB concentration, you have to have a larger or a higher partial pressure of oxygen. So that means affinity decreases. So left shift, affinity increases. That means tissue delivery of oxygen decreases. In right shift, affinity decreases or tissue delivery increases. And for fetal hemoglobin, the affinity increases. So that is the left shift. Also, with left shift, this PCO2H plus 2,3 dpg and temperature, everything is decreasing. Okay. Remember, with fall in H plus, there is alkalosis, not acidosis. So with alkalosis, your left shift is happening, and with acidosis or increase in H plus, there is right shift. So with right shift, everything is increasing. That is PCO2, H plus, 2,3 dpg, and temperature. Don't get confused with H plus and acidosis. With rise in H plus, there is more acidosis. And there were 2 questions on gastroenteritis. One was the vomiting, diarrhea within 8 hours or 6 to 8 hours after having some ice cream cake. Another was onset within 4 hours, resolved in 24 hours. So usually with such short incubation period, it is usually Staph aureus. So you have to know the different food infection and the causative organism. If they mention something like fried rice, it's Bacillus cereus. If there is diarrhea and some blood stain, can be Salmonella. So those are the things, but with short incubation period, it's usually Staph aureus. Now VSD murmur, why it is not heard at birth. So what happens in VSD is there is a ventricular septal defect. So in ventricular septal defect, the blood flows from left to right. But soon after birth, the pulmonary pressure is very high, so it does not allow this shunt. That is why there is no murmur. But as the pulmonary pressure falls and the left-sided pressure increases, this blood starts to flow from left to right and there is murmur. So it is due to high pulmonary pressure. Now Duhamel pull-through procedure, which is done for Hirschsprung, which is the nerve injured. So it is, and it is mentioned that it is causing problem with the voiding of the urinary bladder. So in urinary bladder, the sympathetic nerve is for the filling of the bladder. Parasympathetic is for voiding. So pelvic splanchnic nerve is for the parasympathetic innervation, which is for the detrusor contraction. And the pudendal nerve is for the external sphincter, which is giving the voluntary control. Another scenario, mixed incontinence, that the patient had stress incontinence, that is incontinence with cough and some straining. There was urge incontinence and there was overflow incontinence. So you have to know these terms. What are the initial management in stress incontinence, usually in a multiparas lady and all, due to pelvic floor weakening. The first line is pelvic floor strengthening exercises. Urge incontinence, oxybutynin, anticholinergics, those are the management. In overflow incontinence, what you give, those things need to be clear. Now in a prostate enlargement with raised prostate specific antigen, what is the first line management? So it is first line is alpha blockade with follow PSA. The option also included 5-alpha reductase, but the first line is alpha blockers like prazosin, doxazosin. Now there were questions on major depression, dementia. So you have to know what is depression, what is dementia, what is delirium, what is schizophrenia, what is post-traumatic stress disorder, what is complex bereavement disorder. So to make it simple, delirium is like in an elderly, maybe they are admitted in ICU and it is very acute. There is disorientation and due to maybe some underlying infection, fever, okay, that is what delirium is. It is mainly disorientation, memory impairment, all those can happen. Now with depression, there is suicidal intent, there is disinterest, lack of interest in everything that they seem to have attained pleasure previously. Now they are having lack of interest, lack of sleep, and suicidal intent. It's likely depression. Now after a bad event, if the patient is having recalls of that event, they are avoiding any situation that is reminding of that event, that is usually PTSD, post-traumatic stress disorder. Now again, after that event, if they are having suicidal intent and all, think of depression. If after loss of some close member, loss of a loved one, they're having problem with sleep, they're having problem with their activities of daily living, that could be a complex bereavement disorder, because bereavement can prolong from person to person. It can extend up to 1 year. So just based on the duration, you cannot say if it is depression, but based on the severity of symptoms, you can say whether it's depression or complex bereavement disorder. Okay. Again, in dementia also you can have some hallucinations and all. But what happens in schizophrenia is you're having thought disorders, like you're thinking that your thought has been broadcasted, or there is some thought insertion, somebody's controlling your thought. These could indicate schizophrenia. Again, there is hallucination, delusion and all. Also, there are some personality disorders which are like schizotypal, which means there is magical thinking, like they have some power, but there is no severe symptoms like in schizophrenia. So that is called schizotypal, mainly translating to magical thinking. You can think like magical thinking, that is the key word there. Schizoid means loner. They are avoiding social interaction, they are usually alone. So that is schizoid personality. It's actually only a personality disorder. It's not like a major disorder like schizophrenia. The schizotypal and schizoid are personality disorder. Then there is also schizophreniform, which means the duration has not extended up to the categorization of schizophrenia, but they are having everything related to schizophrenia. And they may resolve also. That is called schizophreniform. Then there is schizoaffective disorder, which means schizophrenia along with depression. So I just told all this so that you familiarize with those terms. You have to know different terms, especially in psychiatry. They are asking so many things from that. Now, MSc, which is mini mental state examination, there was one question which mentioned what is true about MMSc. So the option was 24 is the cutoff. So 24 is the starting of mild cognitive impairment. So that it is a score out of 30. About 24 is okay. From 24 down, it is mild cognitive impairment. And the other option was it is not a standard test, but it is a standard test. And 24 is the cutoff, and it is mild cognitive impairment when it is 24. Now, mild depression, what is the management? It's cognitive behavioral therapy initially, and you can go for in depression especially. It is first line is SSRI, but you never give SSRI and MAO inhibitor together. You have to stop SSRI if you are switching to MAO inhibitor. Now, another patient was unable to recognize face. What is it called? It is called agnosia. So you have to know what is agnosia, what is apraxia. Apraxia is the inability to do a learned act, like you're maybe brushing your teeth. It's like a learned activity that you don't have to think much. You take the brush, you apply paste, and you start brushing. It's like a learned activity, but they forget that. So that is apraxia. Alexia, it is the inability to read. Agraphia, so those terms should be familiar. Now, lithium, how much time does it take for lithium to attain stable state? It is 4 to 5 days. Now, the levels of lithium is usually checked 12 hours after the dose. Now, a patient is on lithium and all, there is tremors, seemed like a lithium toxicity. So what is the next step in management was the question. So the option included hemodialysis. That seemed like the answer, but I don't remember the whole step. Now, in primary biliary cirrhosis, what is the drug of choice? It is ursodeoxycholic acid, and it is anti-mitochondrial antibody which is possible. Now, another patient with intoxication that has been pinpointed, so it is opioid toxicity. What is your drug of choice? Naloxone. You have to know the different poisoning and intoxication in the drug of choice. Now, in the patient with dependence showing signs of irritability, lacrimation, there were options which include amphetamine, cocaine, alcohol dependence. It didn't make sense to me. There was I don't know what the answer was, but the question said there is irritability and lacrimation. Now, another where the ABG is given, only thing was carboxyhemoglobin was high. So what do you give? You give high flow oxygen. Now, another question to label the cerebellar vermis, pons, medulla, and all. So this is your pons. This is medulla. This is cerebellar vermis. This is the cerebellar tonsil. And this here is your fourth ventricle. Now, another scenario about right cerebellopontine junction tumor. So CP angle tumor, your nerves affected are 5 and 8. 8 is with hearing and 5 is with facial sensation. So you have to know how to differentiate between Meniere's disease, acoustic neuroma, CP angle tumor, which can be a vestibular schwannoma. So they can either give CP angle tumor or they can give vestibular schwannoma. Mainly the affected nerves is 5 and 8. Then also cavernous sinus thrombosis, where there is a combination of 3, 4, 6, 5 also. It can get affected. A post-op fever. The question was on day 3, but you have to know which are the usual causes of fever. First day, it is wind, which is atelectasis. Day 3 and all, it's water, which is UTI, especially in a catheterized individual after operation. Then wound, especially if there is signs of wound infection like pus discharge or redness or tenderness. Then walking, especially after a period of immobilization, which can predispose to pulmonary embolism in a patient with DVT. Then any day, not just more than 7, any day it could be drug-induced fever. And a patient who is admitted in ICU had received higher-end antibiotics, now presenting with diarrhea while opening 6 to 7 times. So what is the first-line investigation? So it is a Clostridium difficile-based tox assay. Now, post-op oozing from surgical site can be antifibrinolytic deficiency. The neuroendocrine tumor of GIT, which is showing chromogranin as high. What is the other thing that could be high? It is gastric. Risk factor for esophageal adenocarcinoma. So esophageal lining is mainly squamous epithelium. So in esophagus, it is mainly squamous cell carcinoma. But in a patient with chronic GRD, there can be, due to the repeated exposure to acid, this squamous epithelium can get replaced by the columnar epithelium, which is called metaplasia, or Barrett's esophagus, and that can predispose to adenocarcinoma. In squamous cell carcinoma, it is usually in the middle 2/3 of the esophagus, but adenocarcinoma, since it is due to the Barrett, it is in the lower 1/3 of esophagus. Now, in a patient who is diagnosed as esophageal adenocarcinoma, what is the next step? It is oncosurgical referral for staging and treatment. Now, patient with a lesion in the cervix, it is 1 centimeter. So you have to know the cervical screening, the HPV vaccine, the strains of HPV which are causative for cancer. It is mainly 16, 18, 31, 33. And the vaccine is Gardasil, usually given from 11 to 13 years. You can give even after. From 30 years, if you're starting for cervical cancer screening, if you're doing it 3 yearly, do pap smear. Or if you're doing a combined pap smear with HPV, you can do it 5 yearly. Now, if there is any doubt in the pap smear, you can right away do an HPV. If that is also positive, you may have to do a biopsy. So biopsy, it can be cone biopsy, punch biopsy. You have to know what do you do and when. And also the treatment. So cervical cancer is important. Another question on inferior wall MI management. There were 2 questions actually. One was clearly mentioned that the time of onset of chest pain is 30 minutes. So door to balloon time is supposedly 90 minutes, but they say you can do it as late as 12 hours, because if it is ST elevation MI, the main treatment is PCI only, because in ST elevation MI there is already an infarction. So in order to save the heart muscle, you have to do a revascularization therapy, which is the coronary intervention, percutaneous coronary intervention. Now another scenario of mesenteric ischemia in a setting of AF. So if a patient is coming with acute abdominal pain, which is and the tenderness is, it is exaggerated pain, then it could be mesenteric ischemia. You have to do angiography to rule out mesenteric ischemia. Now in a patient who had history of acute pancreatitis previously, now coming with a mass, it could be pancreatic pseudocyst, and the treatment is cyst gastrostomy, that you are percutaneously puncturing the cyst and you are connecting it with the stomach so that it drains into the stomach. Cause of death in a person with pneumonia and liver disease. So if patient had liver disease, some transaminators. Now coming with pneumonia, after 2 days of pneumonia, they die even after starting of antibiotic. And the option included Wilson, acute hepatitis, alpha-1 antitrypsin deficiency, alcoholic liver disease. But it was not alcoholic liver disease because AST was not that much high. Because in alcoholic we say AST is 2 times more than ALT, but it was not the case. So the question didn't make sense to me. It seemed like some underlying lung and liver disease, maybe due to Wilson or alpha-1 antitrypsin. Now coming with pneumonia, and they die due to decompensated maybe liver disease and the infection. Another scenario where the renin was high, the potassium is low. What is expected in USG? They gave different options like one kidney is small, both kidneys are shrunken, adrenals are enlarged. Now, another scenario where there is hypertension, and it mentioned something which indicated that there is renal artery stenosis. You have to do MR angiography to diagnose it. Now, patient started on tamsulosin. Remember, they can present with orthostatic hypertension. That was the question. Now, FE1 by FVC normal, FVC and TLC is low. That is indicating fibrosis. You have to know spirometry and what all the parameters indicate. So for obstructive, it is mainly FVC. Restrictive, it is FVC, which is indicator. It is FVC becomes low, but FE1 by FVC remains normal. But in obstructive, FEV1 becomes low. So the ratio also reduces. FEV1 is low in obstructive diseases like COPD, chronic obstructive pulmonary disease. Now, a patient who is having long-term contact with birds, rearing bird as a pet, now with shortness of breath, X-ray showing reticular shadowing, what is your next step? So, to rule out fibrosis and all, you have to do HRC. Cause of death in epithelial ovarian cancer, it is pulmonary embolism. Infection was not among the option. Otherwise, infection is also one of the cause of death, but it is pulmonary embolism. Most common cause of episiotomy wound dehiscence, it is infection. Now, why is median episiotomy better than mediolateral? It is because blood loss is less and repair is easy. But otherwise, the rectal sphincter involvement and all is more with median. But the repair is easier and bleeding is lesser in median. A patient who is 28 weeks pregnant, coming with only 2 movements in 24 hours, 2 fetal movements in 24 hours, what is your next step? So it is biophysical profile. You have to know what all comes in biophysical profile. It is NST, your fetal movements, all of those things. So you have to know what is biophysical profile. Now, labial fusion in a young girl, what is your management? Do you straight away give estrogen, or do you wait until puberty to manage? Now another scenario of imperforate hymen, a girl of 17 years coming with primary amenorrhea, secondary sexual characters are okay. On vaginal examination, there is some bulging of membrane, there is suprapubic tenderness and suprapubic mass. So that indicates imperforate hymen. So you have to know how do you differentiate imperforate hymen. The androgen sensitivity syndrome, who is actually genotypically male but maybe raised as a girl because of external characters like a girl. Then there is Turner syndrome, who is again coming with primary amenorrhea, short stature, wide spaced nipple, webbed neck. Okay. There is rudimentary ovaries. There can be Mullerian agenesis, wherein there is no uterus, no cervix, no upper part of vagina, because all of these are coming from the Mullerian thing, and no fallopian tube. But the ovaries will be there because ovaries are coming due to the genetic makeup. So ovaries will be there, but no uterine structure. So that is Mullerian agenesis. So these things you have to know. So this all can come with primary amenorrhea. And also primary amenorrhea also you have to rule out pregnancy, because if the secondary sexual characters are okay and the girl is sexually active, you have to always rule out pregnancy, because that can be coming as primary amenorrhea also. The post-cholecystectomy coming with some problems. So it is clipping of GB duct. Now patient with trochanteric bursitis, where there is pain in the left lateral part of leg, there is also tenderness. So how do you manage it? Is physiotherapy with restricted movement. Another scenario, rotator cuff tendinitis. So you have to know what is adhesive capsulitis, what is rotator cuff tendinitis, what is rotator cuff tear. Adhesive capsulitis is like frozen shoulder, wherein there is complete restriction of movement in all the directions, and it is usually in diabetes. It's called frozen shoulder. So as the term, it is restricted in all directions. Rotator cuff tear is when there is a problem with the abduction, and there is draw palm test is all positive. But in this question, it was said that the draw palm test is negative. There is tenderness over there. That is rotator cuff tendinitis. Now, in a girl with ITP, how do you manage the definitive management? The option both included both prednisolone and IVIG. Definitive would be IVIG. If it is not responding to any medical management, you may have also to go for splenectomy. A patient with granulomatosis with polyangiitis, wherein CNK is also positive, so that can come with sinusitis, glomerulonephritis, and pulmonary hemorrhage. So they ask, what else will you find? So due to pulmonary hemorrhage, they can present as hemoptysis. That seemed like a bit tricky question. They mentioned also hemothorax and hemoptysis. Since there is pulmonary hemorrhage, there can be hemoptysis. Now AML, you have to know how do you differentiate AML, ALL, CLL and CML. So LL is the most common malignancy in children, especially also in a setting with Downs. And AML, they usually mention O-ROD. And AML, the presentation of APML is with DIC. So there can be O-ROD. And APML, which is AML M3, can present like DIC. And the treatment of choice for APML is ADRA, which is all-trans-retinoic acid. All-trans-retinoic acid, because the translocation is PML-RAR alpha. So all-trans-retinoic acid, which is 1517. So APML is 1517, which is the translocation there. Then you can have CLL, where there can be thrombocytopenia, splenomegaly, lymphadenopathy, again in elderly. CML, you can have platelets can be high here. Platelets can be high, and leukocyte alkaline phosphatase. that is low, and CML, the classical is your Philadelphia chromosome, or which is called 922, or BCR ABL, 922 or BCR ABL. Okay, so this is how you differentiate. Now, myasthenia gravis with the ocular palsy, especially worsening in the evening. Now, patient with DM, tiredness for 2 days, ECG showed Q waves in V1 to V4. It seemed like a myocardial ischemia like state. What is the next drug will you add? Verapamil, diuretics, AC inhibitor, amlodipine. It didn't make sense to me. I didn't understand what the question tried to evaluate. I didn't understand that. This was a scenario. Now, a patient with pneumothorax and GCS is also less than 8. What is your first step? So you have to secure the airway. It is intubation. The option didn't include needle thoracostomy. It only included ICD insertion. Before securing the airway, you cannot go for ICD insertion because ICD insertion is going to take some time. So you have to first secure the airway, especially when the GCS is low. Abdominal aortic aneurysm, the initial test is ultrasound. Group A streptococcus, what is the treatment of choice? It's penicillin. Pathophysiology of preeclampsia, it is placental ischemia. Actually, it is a problem with the trophoblastic invasion, but the option included placental ischemia. That is the pathophysiology. Then there was question on late onset IUGR. What is the cause? I don't remember what the option were. Then what is Sheehan syndrome? What is Escherman syndrome? You have to know. Especially in a setting with previous postpartum hemorrhage, think of Sheehan syndrome. Previous DIC and previous DNC and abortion, think of Escherman syndrome. Now, congenital adrenal hyperplasia, what is the investigation of choice? That is 17-hydroxyprogesterone, which will be high. Now, another thing about functional tremor. So you have to know what is essential tremor. Essential tremor, there is familial history with the tremor while usually doing activities. And the treatment is beta blocker, propranolol will be the choice. Then there can be, there can be cerebellar tremor, which is again intention tremor. There can be Parkinsonian tremor, which could be pill rolling tremor, which is like the resting tremor. Then there can be hyperthyroid tremor, which is like fine tremor. Here it was like after acute stress event, the patient is having tremor, and the speed of the activity, like when they are being asked to do the dystidocokinesia, the speed of their the activity adjusts to their tremor. That is what they mentioned in the question. So it seemed like a functional tremor. Now, another scenario of neuroleptic malignant syndrome, a patient on antipsychotic coming with hyperthermia, the hyperreflexia and all, that is neuroleptic malignant syndrome. The treatment is dantrolene. Now, another scenario wherein they explained Wenke-Pack phenomenon, that is progressive prolongation of PR interval until one QRS drops. That is a explanation. So they asked what is this type of heart block. It is Mobitz type 1, which is Wenke-Pack phenomenon. Mobitz type 1 is there, Mobitz type 2 is there. Mobitz type 2 is where there is some P is not conducted, and it can very well go in for third degree heart block. Mobitz type 1 is when there is progressive prolongation of PR until one P is dropped. See if you can see here, the PR interval is this much in the first setting. It increases. Then here it drops. There is a small P, but it drops. There is no QRS. Then again it comes. Then it drops. Okay. Then a child with dehydration, what is your first line investigations? Urea and electrolytes. Then a boy with asthma who was controlled with the inhaler. There is now no signs on physical examination, but recently he's having to use, he's around 17 years, he's having to use that inhaler frequently, and he is reluctant to use it in front of his friends, in front of his newfound friends. So what is your first thing that you will ask? And the option included probe smoking history. So since the patient is having no symptoms currently, but he's having some increase in use of his nebulizer, which inhaler, it indicated some kind of a new smoking activity. So probe smoking history. Now another question where there is lymph node which is showing necrotizing granulomatous inflammation in biopsy. The AFB stain is negative. They mentioned like mycobacterial stain is negative, and fungal stain is also negative. What does that indicate? And the option included that you can rule out TB, but that is not the case. Just because AFB is negative in a necrotizing granulomatous inflammation, which is highly suggestive of tuberculosis, you cannot rule out tuberculosis. You may have to go in for further tests. That was the another option. You need more tests to exclude mycobacterium. Another option was it is due to fungal infection, but since fungal stain is negative, you may rule out that. Another option was that the necrosis is due to ischemia. It is not due to ischemia. The pathophysiology is different. Now another scenario of 6-month-old with cough. The question was a bit confusing. Option included some throat swab, some antibiotic thing, and another was a 5-year-old with fever. So again, the option included antibiotics, IV fluids, and all. So this is the overall idea of the questions. Again, I would not say that this is complete. Do your work, read, and especially try to differentiate between the closed differentials and identify the keywords. All the best for all of you. Thank you so much.